Thanks, Dr. Putnam. It's a pleasure to be here. I was going to thank the organizers for inviting me to speak to you today, and then I realized I was listed in the program as one of the organizers, and that would be self-serving. So I'm not going to do that, but I would like to thank APFED for choosing Denver as the site this year, and we hope to have you back in years to come. We hope you learn a lot from this. I appreciate the applause. Thank you. Okay. We're all in the... So those of us from Denver would like to have you back as well. My talk is allergies and EGIDs, and the gastroenterologists here have shown you several different pictures of the gastrointestinal tract, so I think I would be remiss if I didn't talk a little bit about some pictures that have to do with allergic disease. And the reason I'm doing that is a lot of the people who have eosinophilic gastrointestinal disorders have comorbid allergic disease. So if you can bear with me for a minute, it's not quite as graphic as the pictures they showed you, but these are the things we're looking for when we examine patients who come in with complaints about food ingestion and may have eosinophilic gastrointestinal diseases. First of all, when we examine them, we're looking for the clear rhinorrhea, clear runny nose that goes along with allergic rhinitis. We're looking for the transverse nasal crease. This is likely a patient like this who's in the middle of an allergic reaction during the pollen season and has so much nasal congestion and mucosal edema that the nostril is completely closed, can't move any air through it. So you've got the nasal obstruction, you've got the clear rhinorrhea. Itching is another feature, and allergic patients have several different annoying things that they do. They have the allergic salute. If they do a lot, there are multiple versions of that you'll see, and I'll have patients tell me, no, I don't have any problems with my nose, just a second. You'll see that sort of thing. They have the allergic cluck. If you've never heard that, you haven't been around allergic patients. That's because the roof of their mouth itches during the pollen season from the deposition of pollen there and the activation of mast cells that lead to histamine release that cause that itching. If you do the allergic salute enough, you'll get a transverse nasal crease. So this is the other thing I look for in teenagers where I ask them if they have nasal obstruction and they say, no, I feel fine, everything's okay. And I can see the transverse nasal crease, so I know that they likely have persistent nasal obstruction. The other thing we see are these dark circles. They're called allergic shiners, but you get them because you have nasal obstruction for any reason. So if you have chronic sinusitis or if you have non-allergic nasal symptoms with nasal obstruction, you're still going to slow down the blood flow through this area, the capillary blood flow, which tends to be primarily venous and drains into your nose, and you're going to get these prominent dark circles that are referred to as allergic shiners. This woman is a sous chef, and she's allergic to carrots, and she had just peeled a number of carrots and forgot to wash her hands. Her eye itched, and she touched her eye, and she developed periocular edema that you can see here and what we call conjunctival injection. This is another sign you see in allergic patients. These are called Denny-Morgan folds or Denny's lines, and they're because of swelling or periocular swelling that goes along with allergic ocular disease. And then these other findings here are all associated with eczema. And so you can see that eczema is a scaly, itchy, pruritic, red rash that occurs primarily in the creases. It is incredibly itchy, so you see it in the knees of a toddler here. You can also see it around the eyes of this patient. Patients with eczema, because their immune system is a bit compromised, tend to get more warts than other people. And one of the reasons I like this slide is here's a molluscum wart that's sitting right there that would go away without treatment in months. And then these are other examples of severe eczema that involve other than the creases, which shows you how much suffering these patients with allergic disease can certainly undergo. And in the middle, obviously you've seen already, you probably recognize that now. That's esophageal mucosa with eosinophils in it and basilar hyperplasia. So the goal of my talk this morning is to discuss the association between allergic disease and eosinophilic gastrointestinal disorders, and we are going to focus a bit on eosinophilic esophagitis because that's the most common EGIDs that we see, but I'd be happy to entertain questions about the others. And we're going to review the methods used for diagnosing allergies over the next few minutes. So what is an allergy? How do you define it? Well, an allergy is caused by an exaggerated immune response to a harmless environmental substance that we call an allergen. And we think this arm of the immune system involved to help protect us from parasites. So the idea is you have this first host defense. You have, like in your gut, you have mucus, and then you have epithelial cells. And let's say you get an organism like a parasite that bores through that mucus, bores through the epithelial cells, and gets inside the gut. Now how do you get rid of it? You know, you've tried to keep it from getting in, now it's inside. One of the ways you do that is you develop an IgE antibody, an allergic antibody, against allergens in that parasite. That allergic antibody then binds to the surface of a mast cell. Mast cells are cells throughout our body where we come into contact with the environment. So we have increased numbers of mast cells in the skin, in the lining of the nose, the lining of the respiratory tract, and the lining of the gut. So now you've made the IgE, it binds on the mast cell. The mast cell is where we keep histamine in our body and a variety of chemicals that call in other cells. They call the mast cell the sentinel cell because once it's set off, it releases a lot of mediators that call other cells like eosinophils into the area. So now you have the trigger, the IgE molecule that's on the mast cell that's specific for the parasites that's inside of you, and now you've got the mast cell calling in all these other cells and stimulating lymphocytes to develop the right environment to kill that parasite and then expel it from your body. So that's why we think that that's the kind of arm of the immune system that was developed initially to protect us from parasites. And we can talk a little bit more about parasites in the immune system later in this morning's discussion if you'd like. So what are the common allergens? Well, they're pollens, tree pollen, grass pollen, weed pollen. Those are the most common pollens. Sometimes people think, well, I'm allergic to roses or I'm allergic to flowers. Well, generally you're not. And the reason you're not is because those flowers are insect pollinated. They have that beautiful flower there to attract the bee to come by and pick up the pollen and carry that to another plant and dump that pollen off. So that's the way they reproduce. The plants that make the pollens that we're sensitized to are pollinated by wind-borne pollination. In other words, they're usually kind of the uglier plant next to the very pretty plant that has a flower to attract the insect. And those plants know that this is an incredibly inefficient process. So what they do is they produce tons of pollen that gets in the air and gets blown around because really it's kind of happenstance that, it works, but it does work well. So that's why it's tree pollen, grass pollen, weed pollens that we tend to get sensitized to because those of us who have the potential to become allergic are kind of caught in the crossfire of this courting relationship, if you will, and we suffer the symptoms of that. The other perennial allergens are dust mite. We don't have dust mite in Colorado because it's too dry. Dust mites have to absorb mucus through a hygroscopic substance in their knees, so you have to have a dewdrop for them to poke up against to get a drink. We don't have those here in Colorado because it's a dry heat you're experiencing today. So they don't survive. So when I was in practice in Washington, D.C., virtually every child I saw who was allergic had a positive skin test to dust mite. In Denver, I see children with just as significant eczema and other allergic disease, and it's rare that I see a positive skin test to dust mite unless they vacation in Florida or other parts of the country where there are dust mites. Molds or other common environmental allergens. Foods, we're going to spend a lot of time talking about foods. Insect stings can be another allergen as well. So what are the common allergic diseases? It's some of which I've alluded to here. Allergic rhinitis, allergic nasal symptoms, often with associated eye symptoms, asthma, coughing, wheezing, shortness of breath, eczema that we've talked a bit about, and food allergies. So what are the common features of allergic disease? Well, I've already kind of gone over this first point. It's Th2-mediated inflammation, and by that we mean that there's a certain arm of the immune system which involves lymphocytes, and a particular type of lymphocyte called a T helper 2 cell. And when those cells get activated, they release molecules that help mast cells in the area to grow and increase the population of mast cells in that area, and also aid in calling eosinophils into the area. And not only does it call them into the area, but when eosinophils get there, it produces molecules that help them survive and stay active in the area longer. And the eosinophils bring other molecules that when they release those molecules can cause tissue damage. Again, inflammation is an important part of our life and is what keeps us going. It's when that inflammation goes awry or is an over-response or we can't dampen it that we tend to get into trouble. So one of the features of allergic disease is a heightened response to specific stimuli. And in this situation, it's stimuli that are normally harmless. Allergies are also associated with either intermittent or chronic symptoms, and it depends upon your exposure to the allergen. So which allergen are you sensitized to? What's your exposure? So you may have seasonal symptoms alone. If you're allergic to grass pollen, you may do fine the majority of the year, but you have trouble in end of March, April, May, into June, and then you start to get better. Whereas if you're allergic to dust mite, or, God forbid, the cat or dog who sleeps with you, you might have symptoms on a daily basis, although we'd never admit that. And then there's the potential for remodeling of tissues, and by that we've already touched on that a bit this morning, that not all patients who have allergic disease do this, but there is a population of patients who have tissue remodeling. In other words, they get scarring. So as the inflammation flares up again and then comes under control either by medications or otherwise, there's a bit of scarring in that process. We see that in some patients with asthma as another example. So asthma is a very forgiving disease. We see a number of people with asthma whose lung function stays normal throughout their entire life except when they're having asthma episodes. But there's a small percentage of patients who actually lose lung function over time because of continued scarring of their airways as a result of the inflammation. So as allergists, we're always looking for that population of patients that might have more severe disease with long-term loss of function. Now, the other thing that I see as an allergist over and over and over, and Dr. Fleischer is going to focus more on this in his lecture, is what's called the allergic march or the atopic march, or as a friend of mine, Dr. Boguniewicz, says, the atopic marathon, because it goes on for a long period of time. When we're taking histories, usually there's a parental history of allergic disease. Either one or both of the parents is allergic. Now again, you may not have to have significant allergic disease, so I ask a lot of parents, are you allergic? They say, no, I'm not allergic. I mean, I get a little runny nose in the spring and I itch a lot in my eyes. Well, that's allergic. That's enough. Because really all we're asking for, yeah, the guys in particular, no, I don't see a doctor, I don't do anything. But anyway, we won't go into that. So the point is that it doesn't have to be bad enough to take you to a doctor. What we're really asking is, do you have the genes that you could pass on to their children that would make them more susceptible to have allergic disease? So if you're the child in the family, you're at higher risk of allergies if one of your parents is allergic, or both of your parents allergic, even more risk, or if you have a sibling who's allergic. So that's an important part. And then the atopic march starts early in life, oftentimes within the first few months of life, with eczema or food allergy. And one comes first and the other one may follow. And then oftentimes these children wheeze with viral illness. That's usually the trigger that sets them off to wheeze early on rather than an allergen, unless it's a persistent allergen exposure like the animal, like the dust mite, like the moles. And then between 4 and 7 years of age is when you usually start to see the onset of allergic nasal symptoms, because it takes several seasons of exposure to pollens, seasonal pollens, before you become sensitized enough to start to have symptoms. So that's known as the atopic march. I'd like to say that this atopic march is not correlated with medication allergy or with insect sting sensitivity, and the reason I bring that up is a lot of parents who have kids who are so allergic to foods are worried that if they get stung by a bee, they're going to die the first time they ever see one, and that's really not the case. They're generally at no higher risk than the general population. So what about eosinophilic gastrointestinal disorders? What are the common features there? Well, like allergies, it's also Th2-mediated inflammation. There are mast cells, if you look in the areas that are involved in EGIDs. If you stain for them and look for mast cells that have degranulated, you'll see them there. But eosinophils is a predominant cell that we're looking at that's kind of the marker of this type of inflammation. And some of these patients do have significant IgE-mediated processes. So we see a number of children with eosinophilic esophagitis, for example, who not only have delayed reactions to foods if they're put in their diet, but they also have immediate symptoms after the ingestion of the food and may even anaphylax if they're exposed to selected foods. The other common feature is there's a heightened response to specific stimuli. So there may be foods or other allergens that trigger the disease. They have intermittent or chronic symptoms, again, perhaps depending upon their level of exposure to the allergen that's driving the process. And that's why the thought process is if you can remove the allergen that's driving it, you may have maybe symptom-free without the need for medications. And then there's this potential for remodeling of the involved tissues. And you've seen some slides already that showed, for example, in the esophagus, some fibrosis that could occur. And that's obviously what we're worried about long-term in these patients, is that this continuing inflammation will lead to more fibrosis, where in the esophagus in particular may lead to strictures or in other areas of the gut as well. So as you can see, there are a lot of common features between eosinophilic gastrointestinal diseases and allergic disorders. And they're also both on the increase. I mean, the data I'm showing you here shows that if you looked in 1990 for the prevalence of asthma, it was about 3%. Through other studies in 2007, it's up to 7.7%. If you look at atopic dermatitis in 1998, it was about 7.3%. In 2006, 10%. People think this is still on the rise. And if we look at peanut allergy, 0.4% in 1997, 0.8% in 2002, 1.4% in 2008. So food allergies appear to be on the rise as well. And if we look at eosinophilic esophagitis, I mean, obviously this is just selected data, But it does illustrate, and some of this has to do with now that we know more about it, we're recognizing it more quickly, but we think it's more than that, that there's also an increased prevalence of this disease. In Perth, Australia, there was an 18-fold rise over 10 years, and in Philadelphia from 1994 to 2003, there was a 35-fold increase. Now, again, I can tell you as a doctor who missed patients with eosinophilic esophagitis for a period of time before I became aware that it was an entity, I hope I don't miss those patients anymore. I ask a lot more questions now than I used to ask about feeding and response to foods than I used to, and I think I pick up these people better or quicker than I did before, certainly. In fact, we've had discussions in the clinic, how many people today can we diagnose with eosinophilic esophagitis before the end of the day? Yeah, thank you. It was meant to be humorous, yes, thank you. So, what is the frequency of allergic disease in patients with eosinophilic esophagitis? So these patients tend to have an increased frequency of allergic disease. If we look at the general population, about 30% to 40% of the population has allergies, which is why I decided to go into this area, because I figured there are going to be 30 to 40% of the people that have a problem that I need to talk to them about. So that gave me a pretty good group of people to work with. And at parties, you find that you've got a common thing to talk to people about. It's kind of a... so anyway... If we look at these studies, what you'll see that look at large numbers of patients with eosinophilic esophagitis, you'll see that asthma is overrepresented in this group. I mean, 50% of the patients that Dr. Spergel and his group saw, of 620 patients with a mean age of about 9.1 years, had asthma. Allergic rhinitis, 61%. And again, elevated in each of these different studies. Atopic dermatitis. And anaphylactic food allergy is overrepresented in this group as well. So obviously there's some comorbid association between these disorders, or allergies play a role in a significant number of these patients. Not all, but in a majority of these patients. So what do allergies have to do with eosinophilic esophagitis? Well, the majority of patients that we've talked about, if you look for markers of allergic disease, like their total IgE antibody level. Now again, IgE is the allergy antibody level, So if you look at their total level, is it elevated or not? Because people with allergies, one of the ways you distinguish them from everybody else is they make increased amounts of IgE. So 80% of these patients have elevated IgE levels, or the majority have evidence of sensitization to a specific allergen by a positive prick skin test, or an elevated serum allergen-specific IgE level, or not through an IgE-mediated mechanism, but through lymphocyte activation, perhaps, by using the Atopy patch test, which is used for foods in patients with eosinophilic esophagitis. So it's important that we take a minute to distinguish sensitivity from allergy. There are a number of patients who have positive skin tests or positive blood tests to a food, for example, but can eat that food without a problem, particularly if we're talking about anaphylaxis or systemic reactions. So those patients would be labeled sensitized, but not necessarily allergic. The thing that makes it allergic is I eat the food, I have the sensitization, I eat the food, I have symptoms. So that's what makes it allergy. And the reason that's important is there are a lot of people running around with a positive skin test to a variety of foods that they eat in their diet on a regular basis, and it doesn't cause them to have symptoms. I have to say, as an allergist, I have to rethink how I interpret skin tests in patients with eosinophilic esophagitis, and I'll try to make that clear to you as we go through the remainder of the lecture, and why I think that's important. But the point I want to make is there is some noise in the system. You may have a positive skin test. You may not necessarily react to that food. So how do we determine what a patient is allergic to? Well, there are three different ways that we do that. As I mentioned before, we do skin testing, we do laboratory tests looking for allergen-specific IgE circulating in the bloodstream, and then we do Atopy patch testing to foods. So we'll start with skin testing. Basically, we take a commercial or a freshly prepared extract. I tell everybody we have a thing that looks like a blue toothpick. You dump it in a well of the allergen solution. It's sharp on one end. We're going to place it on your back. It's like flicking a fingernail on your back. That's about the level of pain that it imparts. And in 15 minutes, if you're allergic, you're going to itch like no other, and that's going to be the part that's going to bother you the most because you can't scratch it until we're done. And so what you can see here is an example of a positive skin test in a child that's less than 3 years of age. This part's called the wheal, so that's the bump, and this is the area of redness. So what's going on is you introduce the allergen into the epidermis, the allergen diffuses through the epidermis, and there are mast cells in the lining of the skin, and these mast cells have IgE on their surface, several 100,000 molecules of IgE on their surface. And if some of those molecules are specific for, let's say, the milk allergen that we put in here, then if two of those come close together and bind to that allergen, that'll tell the mast cell there's a foreign invader. So he thinks, or it thinks, there's a parasite coming in here. I've got to do what I do. So it releases all of these granules and mediators that then have an impact on the surrounding blood vessels that leads to leakage of fluid into the area and dilation. So the dilation of the blood vessels is where you get this redness or erythema, and the leakage of fluid into the skin is what leads to the wheal. So that's what we're measuring in 15 minutes to see. Now again, size of the skin test, I want to tell you, doesn't tell you severity of reaction. Doesn't predict severity of reaction. It predicts likelihood of reacting. So the bigger your skin test, the more likelihood you'll do something, but it doesn't predict you'll have a severe reaction. So what do we use for skin testing? Well, we can buy commercial extracts. Other people have made these extracts and sell them to us. So the ones we tend to use for foods or allergens, other allergens, are glycerinated extracts so that they don't auto-degrade. They keep fresh, and they're 1 to 10, 1 to 20 weight to volume for the most part. In this particular disorder, we tend to like to use freshly prepared extracts of foods, and I'll talk to you about why in a minute. We apply them by the prick technique. We don't use an intradermal technique for food skin testing. It's more sensitive than it needs to be. The likelihood of a systemic reaction is higher, although it's still relatively small. But we don't use intradermal testing for foods, except in one specific situation that we can talk about if you'd like. And this data, or these data, really come from using skin tests to predict likelihood of a systemic reaction, not eosinophilic esophagitis. And I think you have to look at it a little different in eosinophilic esophagitis because it's a different situation, and I'll explain. But if you're looking at people who are going to have an immediate allergic reaction, if you have a positive skin test, your likelihood of reacting is less than 50%. Back to the point I made, there are a lot of people who are sensitized but aren't necessarily allergic, can tolerate the food without a problem. And then the negative predictive accuracy of a skin test is actually very good. It's about 95% if you're talking about classical food allergy. The point is, if your skin test is negative, the likelihood you're going to have an IgE-mediated reaction is not great. Now, in eosinophilic esophagitis, there are combined mechanisms. There's IgE-mediated reactions, and there are lymphocyte-driven aspects of this. So you might have a reaction to a food you have a negative skin test to. You have to keep that in the back of your mind, and that's why people thought about performing Atopy patch testing. So what foods do we select? Well, I have to say, we look at skin tests based on the history. What has the patient reacted to? What do they think is a problem? We're looking at most of the foods that are in the patient, most if not all of the foods that are in the patient's diet to see if we can find a response. And then we're obviously looking at major foods that are known to cause symptoms that might, are the common ones. And we're looking at foods that might cross-react with other foods that they think have caused symptoms in the past. And we don't ignore suggestive history. Even if the skin test is negative or the blood test is negative, we still follow up on that. So the thing I want you to think that's different, or the thing that makes me think differently about eosinophilic esophagitis is I think Dr. Putnam and others have said it's like eczema of the esophagus. So when you're thinking about systemic reactions to foods, what happens is, you have immediate symptoms when you get exposed to the food you're allergic to in the oropharynx. If you have IgE-mediated sensitivity, you get itching and tingling. And when you swallow, you're going to feel throat fullness. But then it goes all the way down the tube into your stomach, and you're collecting that allergen in your stomach, and then it's being absorbed along this area and sent out to the rest of your body to cause an allergic response. But in eosinophilic, and in the stomach, you need to remember that there are peptic enzymes that digest proteins, and most allergens are proteins, and there's an acid pH. So when you swallow food allergens, some of them are rapidly denatured, and oftentimes the allergens that are in fruits and vegetables, when it hits your stomach, it gets digested pretty quickly or degraded pretty quickly, which is why some people have primarily oropharyngeal symptoms after the ingestion of foods but don't go on to anaphylaxis. They don't get enough absorbed to cause the anaphylactic event. So the esophagus is an interesting organ because really nothing comes between the food and it to digest it before it gets there. Basically, this person is doing their own little food challenge by chewing up the food allergens, making it into a great allergen extract, and then sliding it down their esophagus. Now, it's one thing if that's an intact esophagus and you don't have other allergic disease. It might be different if you have a barrier abnormality here because you have eosinophilic esophagitis and you already have allergic inflammation, or you've been refluxing stomach acid up and down your esophagus and have destroyed the barrier as well. Now you're going to have abnormal exposure to a food allergen that may well play a role in continuing your allergic inflammation. So when you think about it like that, it makes more sense to me that you might want to use fresh extracts to foods in skin testing. You'd like to use the food that the patient puts in their mouth. And so we oftentimes have, we go through the patient's diet. We have them bring in the small amounts of the fruits and vegetables that they eat on a regular basis. and the barbecue sauce and the ketchup and the other things, and we skin test them to that because that's what they're putting in their mouth. If they want to keep it in their diet, we'd like to know, do you have a positive skin test response or not? Now again, there are reasons we do it. One is, that fruit and vegetable extracts can be unstable. So if you bruise a fruit, if you hit a fruit, it bruises and then walls off that area to protect itself. So it auto-digests, which is one of the reasons that commercial extracts for fruits and vegetables sometimes don't have all of the allergens in them, and that's why we use fresh food extracts. I may not have a commercial extract to gummy bear, but I can make one if you'll bring it in, and we'll see how that works. And then sometimes we have a negative response to a commercial extract, and we're looking to see, this happened to me a lot when I first started, well, once or twice, and then it's kind of like shame on me, where the child presents with an allergic reaction after soy, a soy formula. We skin test to soy. Skin test is negative. I say, eat the soy formula. It breaks out in hives in front of me. Skin test them to the formula. Skin test is positive. Obviously, there are allergens in that soy formula that weren't in the commercial extract. Duh. So that's why we use fresh extracts. Now, the thing you need to be cautioned about is these extracts are not standardized. And so, and you can't standardize them well. You can standardize the way you make them, but you can't standardize them well. But we think it adds additional information in the evaluation of patients when you're trying to make decisions about which foods to remove or which foods to include in the diet. So why is it that some skin tests, you get them one place, they're one way, you go to another doctor, they're different, or sometimes, which is even worse for me, when we did the skin test before and now they're different and people are looking at me like, well, explain that one, Well, I'm gonna say it could have been the allergen extract. Maybe the allergen extract doesn't contain everything that's in the food. Or maybe we use a different allergen extract in another allergist, or maybe it got older. I mean, we really change our extracts out and watch for that, but that's a possibility. Maybe it's the device we used. Some people have a device where you can do multiple skin tests by pressing it on the skin. You have to be really careful about how you do that. If you press too hard in one area, you might get a response to the pressure, and you might completely miss in other areas, so you have to be very careful in using those devices. Sometimes it's the technician. You need quality control in the patient, in the people who are doing this. They need to be doing this on a regular basis, not somebody who, this is my first time, I think I'll skin test you because everybody else is busy. Don't want to be doing that. And then sometimes, believe it or not, kids don't sit still, nor do adults. When you're doing multiple skin tests, they start moving around. So sometimes there's difficulty with application. There can be sensitivity of the skin to pressure. So some people get a viral illness, and after that, if you stroke their skin, they get a hive at the site they're stroked because their skin is sensitive to pressure. You have to factor that in, which is why we do positive and negative controls. Sometimes there's a change in the level of sensitization over time. So if you look at small children, as they get older, they may become more sensitized to more foods and lose sensitization to foods that they were previously sensitized to. That's a well-known phenomenon. You have to watch that. There are also a group of foods that cross-react with pollens. So if you're ragweed allergic, you may well have oropharyngeal tingling and burning after the ingestion of the melons or banana. That usually comes on later in life because you don't get sensitized to ragweed until you're about 4 to 5 years old, and as you grow, you get more sensitized. And so whereas initially you may not have symptoms when you eat these foods, now you may have symptoms when you eat those foods. And then medications can play a role. Every now and then somebody's on a medication that may inhibit skin test responses and we miss it. So the skin test summary is, if you're looking at studies comparing the use of skin testing in diagnosing allergic disease, there are differences by age of the population, geographic area, extracts, and techniques that are used. Again, we don't use intradermal skin testing to foods in particular. Consider the use of freshly prepared extracts. You may find more information there, particularly of foods the patient is eating. You have to remember there may be a low positive predictive accuracy. It may be a little higher in eosinophilic esophagitis. And there's a reasonable negative predictive accuracy. And the skin test, as I mentioned before, does not predict severity of reaction. Okay? So there are people who said, look, I don't do skin testing, and I still see these patients, and I'd like to get some information up front, or I'd like to know, does this patient need a food challenge or not? Can I continue to follow him? Do I need to send him to an allergist? And so the thought was, maybe we could check the level of specific IgE circulating in the bloodstream, and if it was above a certain level, we could say, well, you're definitely going to react, therefore we don't need to challenge you at this point in time, or conversely, your blood IgE level is getting low enough that maybe it's time to look at your skin test and then consider whether you would benefit from a challenge. So Dr. Sampson and his colleagues were very active in challenging a large number of patients and checking their allergen-specific IgE levels. And so for specific foods, we have diagnostic cutoffs if you're talking about classical allergic disease. We don't have these cutoffs for eosinophilic esophagitis. So if you're a child and your IgE level, the egg white, is 7 or greater, you've got a 98% chance of doing something when you're exposed to egg. Again, we have good numbers for milk, good numbers for peanut, and tree nuts we use 15. The other numbers here are not quite as good. Again, above 20 for fish looks pretty good, but you have to be careful about that. There can be differences among fish. We make these probability curves have been constructed where your probability of reacting is on this axis and how it correlates with your allergen-specific IgE level on this axis. The point I want to make is that if your immunocap is negative here, less than 0.35, you still have a 25 to 30% chance of reacting if you're exposed to peanut in this particular instance, and all the curves for the different foods vary. So that if you come into my office with a history of a reaction to peanut and we get an immunocap and it's negative, I'm not going to tell you to go home and eat the food. I'm going to tell you we have to do a positive skin test and decide whether you need challenge under observation. So the same thing applies for the immunocaps. Again, there are different tests that tell you about allergen-specific IgE, and if you're comparing studies, you need to look at age level, geographic population, etc. Not all measurements of specific IgE in kilounits of allergen per liter are the same. If you use a different test, the numbers may be different and may not correlate with those determination points I talked to you about earlier. The determination points predict high likelihood of reaction, but they haven't been for anaphylactic or systemic responses, but haven't been established for EGIDs. An undetectable level of specific IgE doesn't mean that you have no specific IgE. You could have it in your skin, or it may just not be measurable in the blood. The immunocap is less sensitive than the skin test, and that was illustrated in the previous graph I showed you, where you can have a negative immunocap, but you might still react. It doesn't predict severity of reaction either. It predicts likelihood of reaction. So even though your allergen-specific IgE level is higher, it doesn't mean the higher it goes, the more severe reaction you're going to have. It means you're more likely to have a reaction. And it can be helpful in determining the development of tolerance. We tend to follow patients yearly, their allergen-specific IgE levels yearly, and watch them fall. And if they fall to a certain level, we might say that that's low enough that we should consider skin testing and then using those data to decide whether a food challenge is indicated. So what about Atopy patch testing? Well, the problem with eosinophilic gut diseases is that it's not just an IgE-mediated process. There's also lymphocyte and other cellular mechanisms that play a role. So you could potentially have a positive skin test to a food and still react to that food. And the point was how to get at that. And so people thought about patch testing, which is another way to check for food sensitization. And so what they do is they take food extracts that you make up and place them under fin chambers, which are aluminum chambers. They're taped onto the back, and they're left in place for 48 hours. You return in 48 hours, the patches are removed, the skin's washed off, and it's read first at 20 minutes after that to let the skin kind of recover from removing the tape and washing off the extract. But the second reading is 24 hours later, so that's 72 hours after exposure to the food. And the reaction is graded by degree based on the amount of redness in the area and whether you have little bumps or whether you have little blisters, and the number and how severe it looks. And it's proposed as a major aid for identifying foods that may cause delayed reactions through non-IgE mediated mechanisms. Just like the fresh extract skin test of foods, we don't have standardized extracts to all the different foods we use in patch testing, and so that introduces an element of variability among different places that are doing patch testing. And also, this is something that you really need to have people who are experienced in placing these patch tests, making up the extracts, placing the patch tests, and then interpreting once you're reading them. And I'm not going to go through this slide except to say that Dr. Spergel has done some excellent work in looking at positive and negative predictive values of skin testing, prick skin testing, and patch testing in his population. And there are several articles where he goes through that. And his conclusion is that it's a combination of patch testing and skin testing that will best help you select the appropriate diet for patients. Again, if we look back at the Pfizer Symposium that kind of helped define the disease, their statement about patch testing was, although promising results have been obtained in at least one center, the use of the test should be reserved until additional data clearly establishes its value for the diagnosis and management of EE. So again, the point is, you want these patch tests to be done at centers that have significant experience or by people who have significant experience in doing this, and realize that, again, they're not standardized extracts. you know, you need to think about it. Again, one of the points, I see some patients that we patch tested, and when they come back, the extract is dried up or it's not in contact with the skin. The idea is it needs to be in contact with the skin. If you look at most patch tests, you know, to other agents, they're done in a petrolatum base so that you have adherence to the skin for the full period of time. You just need to think those things through when you're interpreting the patch test. So what about peripheral eosinophil counts? Why can't we just draw their blood, look at the eosinophils circulating in their bloodstream, and say, okay, you know, your esophagus or your stomach's getting worse because your peripheral blood eosinophil count is going up. And the problem is, as we've illustrated here, hopefully, you know, these patients have other allergic disease, so their eosinophil count may be going up because it's ragweed pollen season, and it's in the middle of, you know, they're in the middle of the season, and you're tracking that rather than what's going on in their gut. So unfortunately, it's not as simple as measuring a peripheral eosinophil count, which I'm sure all of you know. And alternatively, these total IgE levels go up and down not just from input from what's going on in your gut, but other areas as well. So same sort of thing. You're doing your pollen season, your total IgE level is going to go up, your allergen-specific IgE level is going to go up, and that may not be related to what's going on in your esophagus. I mean, it may be, but it may not. So it's not good enough that you can follow those levels. You know, you still have to take a look at what's going on in the esophagus. So we've already talked about some of these studies this morning. These are the studies that link diet with disease, and basically all three of these studies show that on elimination diet, the majority of patients respond. I mean, some strikingly so. This is Dr. Leah Kouros' group of 160 patients. 97% of them who had eosinophilic esophagitis had symptom resolution and normalization of biopsies on an elemental diet. Now again, that's not something that's easy to do, and it's not something for everybody. But the point is made that if you remove the allergen, they may well get, or they should be expected to get better. And it may not always be the food. If you didn't see this, you didn't know that Johnny was sharing breakfast with Fido this morning and having his oral immunotherapy to dog spit. So you need to think about other exposures in the environment, like aeroallergens and dust mite and animals and molds, and perhaps there's a genetic piece has already been alluded to this morning. And the idea that pollen sensitization plays a role is illustrated by this particular case history that is quoted over and over and over because it's such a clear-cut history of a patient who has increased symptoms during the pollen season, and when they biopsy this particular patient's esophagus during the pollen season, which is the gray areas, you'll see that the eosinophil counts are elevated in the esophagus, significantly so, and if you biopsy this person outside the pollen season, even without treatment, the numbers decrease significantly. So that also makes us think about, and we hear this from patients over and over, about the seasonal worsening of symptoms that we think could well be related to seasonal allergen exposure, particularly in our patients who have gigantic positive skin tests to grasses or weeds or trees. So where are we headed? What do we need to do? Well, we need continued evaluation of the tools that we have available to diagnose allergic disease and whether they're playing an important role in these patients. So we need more studies using commercial extract testing, fresh extract testing, looking at allergen-specific IgE levels. Do they have anything to tell us in this disease disorder or these disorders? And patch testing, how helpful? How can we make them better? Can we refine and improve these diagnostic tests? Can we standardize extracts? Is there a way to do that? Can we standardize procedures? And then we need to identify other potential triggers. So what are the role of these, what is the role of these environmental allergens? Should we be looking at animal dander more and the impact of seasonal pollen exposure? And then we need to continue to search for biomarkers that correlate for esophageal disease so that we don't have to be doing endoscopies over and over and over in these patients. And hopefully we'll have time for people to talk more about what's being done in that regard this morning. And obviously the thing that's not listed on here is a cure. And we need to be looking for different ways to modulate the immune system and these allergies so that we can have a cure rather than just controlling disease by continued avoidance. Thank you very much for your attention. I appreciate it.